Welcome, everybody. Today, we have the pleasure to interview Dr. Francesco Maura from the University of Miami Miller School of Medicine, Florida, United States. And we will talk about this recent paper published on Blood Journal entitled Tracking the Evolution of Therapy-Related Myeloid Neoplasms Using Chemotherapy Signatures. First of all, Mauro, thank you for accepting our invitation. How are you today?
Yeah, fine. Thanks for having me.
It's a pleasure for us. I would like to start this Trainee Pearl episode with you explaining us what we define as a therapy-related myeloid neoplasm, also because we know that recently we've been updated as to classifications, and what was the impetus behind the study?
So the therapy myeloid neoplasm can be simply defined as any myelodysplastic leukemia, myeloid leukemia, or myeloproliferative disorders that occur after exposure to chemotherapy that were given for other tumors. For example, you have an ovarian cancer treated with platinum. The ovarian cancer is in remission. After 3 years, the woman unfortunately developed a myelodysplastic syndrome. These conditions are important on the general population because the number of patients, cancer survivor or patients with cancer in long remission is increasing year by year. And the numbers account millions of people right now in the United States, just the United States. And the risk of long-term complication is becoming more and more important. Among all the long-term complications that patients with cancer exposed to therapies might have, the development of a therapy myeloid neoplasm is usually one of the most unfortunate because the survival for this condition is usually, according to different studies, around 20% at 5 years. So it's a very highly lethal condition that we struggle to cure. And as most of these conditions that we struggle to cure, the reason is not just the genomic complexity of these tumors, it's also because we probably don't understand the biology. We don't have the right drug, and we probably don't know how to prevent this condition, which of course is always the best strategy for most of the tumors. And so the idea is that if we characterize better the genomics and the evolution of these tumors, we can eventually implement and develop strategies of prevention, meaning you can select treatments that are less pro-leukemic or less mutagenic. The last thing is because we are mostly focused on lymphoproliferative disorders, there is a big push over the last years in lymphomas and myelomas, and multiple myeloma of novel drugs. And so some of the paradigms that have been in place for several years, if not decades, which are basically autologous stem cell transplantation with high-dose melphalan, have been progressively put into question. And so these are still extremely valuable approaches, but the number of patients that might need them or might benefit from them is not as big as we thought, or is not as large as in the past. And so it's more becoming important to select the right patients for this treatment, because these treatments are known to have an increased risk of therapy myeloid neoplasm. In a recent study from Dana-Farber on New England Journal of Medicine published in 2022 for Richardson's first name, the termination trial, a randomized trial where patients were allocated transplant versus no transplant, the risk of therapy myeloid neoplasm was 2% at 10 years in the transplant arm versus 0% in the non-transplant arm. So it's 2%, it's not a lot, but accounting for hundreds of thousands of patients with multiple myeloma that every year are treated in this way is actually quite a high number.
So talking about the right patient, thank you for this overview, and maybe we can start pinpointing the characteristics of your cohort in the study design. Like, would you give us some details of which type of patient you focused on?
Yeah, so we started the study at the beginning of the COVID pandemic when my lab was at the Memorial Sloan Kettering. And so we look at the Memorial Sloan Kettering Rich Biobank for patients that had a multiple myeloma in their history that was exposed to high-dose melphalan and transplant and developed any type of tumor. So we found a certain number of myeloid neoplasms. We also find 5 acute lymphoblastic leukemia and 2 solid cancers. In particular, 1 bladder. that was important because the melphalan, which is the drug given in the autologous stem cell transplant, is washed out through the bladder and is known to increase the risk of bladder cancer. To this cohort, we include an historically extremely valuable cohort of whole-genome sequencing data from a study published in Nature in 2015 on TP53 alteration. The first name was Wang et al. And this cohort was around 21 patients plus 2 additional cases we previously published with my friend Nicola Bolli at the Wellcome Sanger Institute. So overall, we have 49 patients. It's an heterogeneous cohort, different treatments. We had 10 patients with the therapy myeloid exposed to platinum and 15 exposed to high-dose melphalan. So what the studies show is that platinum has a very highly mutagenic activity that was already reported by different authors, including in therapy myeloid by Núria López-Vigas lab in Barcelona on Nature Communication in 2021. But what surprised us is that the melphalan mutagenic activity was only observed in 1/3 of the post-transplant therapy myeloid neoplasms. Now, melphalan signatures or mutational signatures, that is the way in which we quantify, or is like a mathematical approach, genomic approach that allow us to identify how many mutations platinum, melphalan, and other like AID or like temozolomide, BRCA, all these different alterations, how many mutations are caused by this alteration, because each mutational process has a distinct signatures. So it's a bit complicated, but long story short is that we can quantify how many mutations can be linked to melphalan, to platinum, or temozolomide. And also we can see that most of the chemotherapies are actually not even mutagenic. For example, cyclophosphamide, or anthracycline, or etoposide. All these commonly used drugs don't cause any mutations. So the melphalan signatures is currently not in the catalog of mutational signatures because it's a recent signatures that was discovered by my lab together with also others that contribute after and validate our signatures over the last 20 years. We have like multiple papers supporting this and been found in multiple myeloma post-transplant, in aggressive lymphoma post-transplant, and now also in therapy myeloid. So the question is why we have 1/3 of patients with the melphalan signatures and 2/3 without. We look into the data, we look at the apheresis samples, we look at very depth, we develop very complicated models to try to understand why this was happening. And the only explanations that pop up was that the clonal hematopoiesis, so the precursors of the tumors, is collected during the apheresis and reinfused after melphalan. And so there is no exposure to melphalan for these tumors. So that was, of course, something people always thought that would be possible. But this is the first real demonstration that a CH can be reinfused.
So you are explaining that we have specific signatures that are associated to exposure to certain drugs, like melphalan, for instance, and so on. So one paragraph of your results section, for instance, focuses on the escape from chemotherapy-induced mutagenesis, right? So does it mean chemotherapy is not the unique NOXA? And what are the implications, for instance, of using leukapheretic products? So this is like exactly what you were like referring to, right? Can you give us some more details?
Yeah, absolutely. So the idea is how much chemotherapy is penetrant. And different chemotherapies in terms of mutagenesis have different penetrance. And there are a lot of people, including our lab, that is working on this, and also seminal papers from other groups like Trainee Pearls in Cambridge, Mike Stratton at Sanger, and Núria López-Vigas in Barcelona. So there are multiple people working on this area of research. So the idea and the data right now suggest that certain drugs like platinum are extremely penetrant. Every time you expose a cell to platinum, the cell acquires mutations independently from cell cycle status. So platinum is very penetrant. And in fact, we found 100% of PMN exposed to platinum had the platinum signatures. If you don't see the platinum signatures, you take a therapy myeloid and there is no platinum, it probably means that the platinum is not detected, because we always have to remember that bulk genome sequencing only detects the clonal event. So if you have multiple clones, subclones, with different platinum mutations, you will not detect them, in particular if the subclones are less than 20%. And that's what we call absence of single cell expansion. So to see a chemotherapy, you need one single cell to expand and take the dominant, because each cell will get a catalog of mutations due to the platinum, and each catalog will be unique because these mutations are relatively random. And so the situation scenario where two cells acquire the exact identical set of mutations, we're talking about hundreds of mutations, it's statistically almost impossible. So taking into account this, we have other drugs like 5-fluorouracil, for example, that are not as penetrant as melphalan. They have been found in certain patients, but not in others. And the mechanism seems to be cell cycle dependent. So you find the signatures in cells that are replicating, like the colon and the GI cell, but you cannot find in cells that don't replicate. There are other signatures that behave in a similar way. We recently, on the Hodgkin lymphoma, found the dacarbazine that seems to be similar. Dacarbazine is not present in all the tissue. Procarbazine instead seems to be present in all the tissues, like more mutagenic, and this data have also been supported recently at the American Society of Hematology conference by the Sangen Institute. So coming to melphalan is highly mutagenic. It's like platinum. And so the fact that you don't see these mutations in therapy myeloid neoplasm, but you see, for example, in some patients exposed to both platinum and melphalan, the platinum, so you see platinum but not melphalan. It's kind of like cannot be explained, because if you see one, you should also see the other, because one single cell expands and the single cell was exposed to both. And so what is the melphalan signature? And that's exactly what you were saying, the escape. The escape is not that the cell escape or create a niche, but the cell is physically taken out from our body, the CD34, during the apheresis, which for people that doesn't know, for autologous stem cell transplantation, we collect the stem cell from the patient. We administer a very high dose chemotherapy that destroys the bone marrow, and then we reinfuse the cells, and the cells will go to the bone marrow and repopulate the bone marrow in usually 20 days. So that's what we do in clinic to allow high dose chemotherapy to destroy residual cells, lymphoma, myeloma, or leukemia. What this mechanism allows is to precursors of these tumors, like a clonal hematopoiesis, so a cell that has, let's say, a mutation that could transform in leukemia. The cell is taken together with the others because we just collect all the CD34, all the stem cells. We don't recognize wild type and mutated. And then the cell is reinfused back. And because it's reinfused back, it basically skips the melphalan. And so this cell was never exposed to melphalan. And when it expands, you will have only the chemotherapy signatures that were acquired before the apheresis. So we have a couple of patients that were platinum and then melphalan, and we can see only platinum, but not melphalan.
Right. So this is also fascinating and explains, of course, like how also the sequential combination of therapies might like imprint and drive clonal trajectories to these patients. So I noticed you also explore copy number alteration and their patterns as compared to de novo AML cases by using whole genome sequencing. Can you comment on these findings and the rationale behind the use of whole genome sequencing as opposed to other sequencing techniques?
So there are like so many omics technology, and in clinic, most of the centers around the world, at least in the Western countries, still use FISH as heterogenetic for most of the characterization of the hematological tumors. But if you think about which technology gives you most information, you need to look which information are you talking about. In the context of primary acute myeloid leukemia, which is considered paradoxically, one of the most simple or simplest genomic, in terms of like genomic tumor across the entire spectrum of tumors, even though the prognosis of these tumors are one of the worst, these tumors, you don't need to do genome necessarily. You can, but most of the key information can be detected with the targeting or with the exome data, because if you can capture copy number and you can capture mutations for clinical purpose. In the term of research, of course, whole genome sequencing allows you to be more broad, to comprehensive, to detect features that whole exome and targeted cytogenetic fish cannot detect, like structural variation, focal copy number, or these complex events, for example, chromotripsis, where like one chromosome is kind of like pulverized, like shattered, and then recombined randomly, creating all this copy number that goes from a allelic deletion to 10, 20, 40, 50 copies of one oncogene, for example. So all this complexity cannot be captured by any other technology than whole genome sequencing. Even all the single cell RNA sequencing, those are even less, like lower in terms of resolution. So the idea to use whole genome sequencing is because when you have a tumor as complex as therapy myeloid neoplasm or multiple myeloma or aggressive lymphoma, exome is not really able to capture the entire complexity. And so you need to use whole genome sequencing if you really want to identify the drivers. If you know what you're looking for, exome is fine. It's also cheaper and it's simpler. But whole genome sequencing is, I think, as a personal opinion, should be the gold standard for exploratory research in the field of genomics. So that's why we use it. The other reason why we use it is because the study was based on the copy numbers, like identification of mutational signatures, as kind of like to stratify and divide our patients and understanding which chemo are mutagenic and which not. And mutational signatures, you need as much mutation as you can. Most of the chemo mutations, if not all, are in a non-coding region. So they're like neutral in terms of cancer evolution, but they are like hundreds. And if you go in exome sequencing, you might not even see them. So that's why it's important to do whole genome sequencing. For copy number changes, what was striking in our analysis is that if you divide patients not according to the therapy they were exposed, not according to the other markers, but you just divide according to presence or absence of chemotherapy signatures, and so that would put, for example, all the platinum in one group, but the melphalan would be split in two. Okay, like the melphalan without chemotherapy signatures in one group and the other one with chemotherapy signatures together with the platinum. You can see that the patients with therapy myeloid neoplasm with chemotherapy signatures have a massively complex genome, many copy number changes, many alterations, many chromotripsis events, while patients with the no mutagenic signatures but with TMN, so we're talking about post-anthracycline, plus BT16, plus after cyclophosphamide, after radiation, they don't have any of this. And their profile of this therapy myeloid neoplasm without chemotherapy damage was identical to the primary AML. And so the idea is the complex cytogenetics that we know is enriched in the therapy myeloid neoplasm and that confers also particularly poor outcome for this patient is probably due to exposure to mutagenic agents that increase somehow the genomic instability. So that's our hypothesis. We haven't proved 100%, but our study, we use this little bit complicated and new genomic way to look at the data, looking when the chemotherapy mutations are acquired in relationship to the copy number gain. So it's a bit complicated, but if you have a copy number gain, like you have a trisomy, the trisomy will duplicate one allele, and all the mutation on that allele will be duplicated as well. So if you look at the B allelic frequency, which means how many reads cover that mutation, a mutation that is present on one allele that is duplicated will be present now in two alleles out of three. And so from 50%, from 1 out of 2, now it's present into 66% from 2 out of 3. And so looking only on the mutation with 66% allelic frequency, clonal mutation within this chromosomal gain, we can look for chemotherapy signatures in these mutations. If you have the chemotherapy signatures in the duplicated mutations, in the vast 66%, the one on 2 alleles, what this means is that the chemotherapy signatures precede the gain, because the mutations that the chemo introduced were acquired before the gain. Then the chemotherapy mutations were duplicated, and now you have on both on 2 alleles out of 3, so 66%. Instead, if you have mutations that are post-gain, so you have before the gain and then the mutations, the mutation will be present only on one allele, 33% VAF, 1 out of 3. It's very unlikely that one mutation occur in two alleles in the same position at the same time. That's very unlikely. So based on this model, what we found is that most of the complex events, chromotripsy with gain or trisomies, were all acquired after the chemotherapy. So the 9 cases we could test this, 9 out of 9 have a chemotherapy that precedes the gain. And so the gain was acquired after the chemotherapy. So that kind of like suggests that probably this genomic complexity is doesn't exist the therapy myeloid, but is induced by our therapies. And so if we think about that the difference in survival between complex and non-complex cytogenetic TMN is around almost 40% according to retrospective studies, you basically, with platinum, you can introduce a lot of this complexity and increase the risk of TMN, but it's not just the risk of TMN, you also increase the risk of developing a lethal TMN, because once you have a complex cytogenetic, the survival is 10%. And so it's very low. And so this concept needs to be, I think, developed in a larger study. Our was a smaller study. We didn't have statistical power to develop clinical correlative or prognostication, but it creates a proof of concept that if we want to look at therapy myeloid, we need whole genome sequencing first. Second, therapy exposure, it's not identical. We need to stratify according to the genomic effect of this chemotherapy, and try to understand how these genomic effects impair the response to the treatment we have now for myeloid neoplasm, and how we can eventually in the future use this information to individualize our treatment. Let's say you have a patient with a CH with p53, and you can choose between a platinum-based therapy and an anthracycline-based therapy. And in that patient, maybe with a large data set, with like robust information, maybe randomized trials, you might get the information that anthracycline might benefit from a long-term effect. All this research that seems to be very futuristic are actually already ongoing in some tumor types, like the Hodgkin lymphoma. The entire research is based now, in particular for the low risk, is not anymore based on reducing the relapse, because the PFS is like 95% or 90%. It's really difficult to even design a study that is powered to detect like 5% significant difference between two arms. So all the studies now are aimed to reducing the long-term toxicity. So we want to get rid of bleomycin because it creates toxicity on the lung. We want to get rid of procarbazine because it is highly mutagenic and increase the risk of secondary malignancies more than dacarbazine, and go on and go on and go on. And so that's, I think, Hodgkin is a perfect model to copy from. Like once you have a very good outcome, you can start to think about long-term complication and put endpoint as a long-term complication.
Yeah, that's like exactly a wonderful point. And I mean, yes, we have like such a good examples in hematology. Hodgkin, and even like, I mean, of course, APL also is another one where like when we start focusing on long-term sequelae, this means we are already done with overall survival, right? So I really enjoyed like reading your paper, and I think this last overview you gave on backtracking the process leading to a fully blown therapy-related myeloid neoplasm, studying this chemotherapy-related mutational signature is definitely one of the key messages of your study and your analysis. But I would like to ask you one last thing. How do you think all these findings will inform future strategies and management of patients undergoing chemo, radiotherapy, and especially autologous transplant, for instance, given also these nuance or maybe like issues of leukapheresis escape and so on?
So I think we are not, and we should not take this study or our previous studies on chemomutagenesis from melphalan platinum in myeloma, lymphomas, and now TMN as something that can change or should change our clinical practice. These are research we don't have to scare our patient, and we should still do what we are doing until we prove that otherwise approach are better. So that's very important. Some people play the mutagenesis as a card against transplant. Some people use for the support the transplant. The field is always divided, but I think we need to be pragmatic. We know it's mutagenic, but platinum isn't a great drug for most of the OBG and tumors and relapse lymphomas, and so sometimes and right now I think we should not change our practice because we are scared about mutagenesis. What is important though is to expand the data availability that might one day change our clinical practice. I always have this example in mind that it's a different setting, but clinical trials should have correlative studies looking for this, for example. So how many patients with transplant, for example, in myeloma, had a reinfusion TMN, and how many have a non-reinfusion? So what was also interesting in our paper is that all the patients with TMN post-transplant in myeloma or lymphoma that have melphalan, so they survived the myeloablative conditioning, had TP53 mutation. So that's kind of like suggesting that there is a specific genomic features that can decide the path that a certain pre-leukemic clone can take, and also, enable a lot of possible investigation. Like every transplant, you just check for CH, you find how many have ACH, and then once you have a lot of patients, you can do some statistical analysis, pulling together data within clinical trial or in observation clinical trial. But overall, you need this information. You need to start this study. And again, people say, oh, that's too hard, that's impossible. But there are experiences already in place, even in myeloma, where 10 years ago there was a big discussion about thrombosis in myeloma, which is the best strategy to prevent thrombosis in myeloma. And the Italians with Torino, Antonio Palumbo and his team, and Boccadoro, they develop all these correlative trials. They have all these clinical trials with pharma randomized trials, phase 2, and for each of these trials, they check the thrombosis as the endpoint, and they randomize patients within an already randomized trial for prophylaxis with heparin, with aspirin, with warfarin, and this information, provide for patients. Most of the patients don't even die for these events, or it just doesn't. The events are not so many to impact the survival in our cumulative analysis, but for a patient having heparin or warfarin compared to having an aspirin, it's a big difference in quality of life. So that's what I'm talking about, is that there are already examples that you can design very thoughtful and meaningful clinical trials with correlative investigations that doesn't affect your primary endpoint to show the treatment is better than another, but provide a lot of information that can change our clinical practice and benefit the patient's experience for treatment, and in our case, reducing maybe the risk or providing information to reduce the risk. Now, when we talk about ovarian cancer, for example, they are so aggressive that I don't think you should hold any therapy. But for example, if you know that the patient has a TPM1D or TP53 mutation CH, maybe you want to follow him over time. Don't wait, that the leukemia just bursts. And we don't have strategies of early detection right now. Like there is a lot of pre-tumor entities. What you're gonna do with the smoldering myeloma? What you're gonna do with the CH with TP53? What you're gonna do with a JAK2 CH with like slightly higher platelets? Are you do prophylaxis? Are you try to eradicate with which drug? And so even if we don't have the right drug right now, it's important to get all this data because it's all about data. If we have 10,000 patients with all this information, you can generate modeling and predict what's the best approach, and then validate that in clinical trial. I think that's really the only way. And as I said before, our study is just a proof of concept on which we can build some of the study. And there are other people like Eli Papamanuel and Kelly Bolton and many others are working on CH much more than us to get to this point, or Ross Levine. I mean, there are so many people working on this. It's like one of the hottest fields, like how we can prevent the tumors and how we can predict the patients that will progress from the one that don't progress. Because of course, you don't want to treat everybody if the progression is like 10% of,
Right.
of the group. So there are so many questions, but the only way is really big data, collaborations, and sharing data when the papers are published, something that still a lot of people don't do, but really, like, we need half of our genomes were from data published from other people. And so that's a clear example of how research can benefit from people sharing correctly the data.
Right. Yeah, that's very important. And thanks for like highlighting this for our trainees that are following us, because I think science is a community effort. So only united we can go and beat cancer. So Francesco, I really would like to thank you on behalf of all the EBMT training committee for accepting our invitation and for today's discussion.
Thank you. It was a pleasure.
Thank you so much.
Okay.
Bye.
Bye-bye. Have a good day.